Next panel discussion. So the next panel is going to focus on the journey in hair restoration and latest breakthroughs in regrowth strategy. I would like to welcome our session moderator on stage, Dr. Sonia Tekchandani, co-founder and medical director, Tender Skin International Mumbai and the Wedding Clinic Pune. Dr. Sonia brings over 20 years of clinical experience, renowned for her exceptional injector skills and keen eye for facial aesthetics. She specializes in anti-aging and laser procedures. She has served as faculty at various prestigious institutions and reviewed articles for the Journal of Cutaneous and Aesthetic Surgery. Joining her will be Dr. Viral Desai, board-certified cosmetic and plastic surgeon and hair transplant surgeon, co-founder and medical director, DHI India, medical director, CPL SS Desai Hospitals and Sarla Hospitals, and founder and medical director, Skin Vibes Clinic. As a member of prestigious associations and with over 20 years of experience, Dr. Viral Desai has transformed the lives of numerous patients, including celebrities, through his exceptional skills and understanding of their aesthetic goals. He is a scientific board member of various organizations and has given over 150 presentations globally. Also welcome Dr. Gitanjali Shetty, Director, Revital Skin Clinic. Dr. Gitanjali is dedicated to helping individuals achieve their desired complexion. With expertise in anti-aging treatments, acne resolution, and hyperpigmentation, she is recognized as a leading dermatologist in Mumbai. Her commitment extends beyond immediate improvements as she educates patients on skincare techniques and suitable products for long-term maintenance. Dr. Vinay Choksi, Chief Hair Transplant Surgeon, WOW Cosmetology Center and Richfield Hair Forever. With expertise in hair restoration, Dr. Vinay has conducted over 1 lakh plus surgeries under his team and trained 110 surgeons in hair transplant and trichology. Having managed 25 hair transplant centers across the country, he brings extensive experience and knowledge to his practice. And Dr. Avinash Agrawal, Director and Partner, Acube Aesthetic Clinic. Dr. Avinash brings over 15 years of expertise in hair restoration surgeries with a track record of over 4,600 successful procedures nationwide. He specializes in advanced techniques like FUT and FUE surgery, as well as scalp micropigmentation and eyebrow microblading. He is a trainer and avid practitioner for scalp micropigmentation and eyebrows microblading and pigmentation and has trained over 300 plus doctors. I would now request Dr. Sonia to take the discussion forward. You would have 50 minutes for the panel and then we could have questions if any. Over to you, Dr. Sonia.
Let me welcome you all to this Aesthetic Medicine India. It's 5 years old now and we've been contributing every year on year, and I have eminent panelists with me who need no introduction. Shriyal has also given a flattering introduction of all of them. Now let's see journey in hair restoration, latest breakthroughs in regrowth technology, and what options you have to plug in for each and every case. We'll take you through the newer treatments and medical line of treatment and the surgical aspects. So I have Dr. Gitanjali here, who is going to address more on the medical part. I have only 1 against 3 surgeons. Can you imagine a tug of war? But I'm sure Gitanjali is enough for 3 of them. So let's go one by one. Dr. Viral, you know about his skills. Let me start with some funny discussion to begin with. All the time talking about, you know, academics and treatments and newer treatment modalities and all that. So let me start with Dr. Avinash. Yeah. Can you enumerate 1 funny incident in your hair restoration journey?
Okay, I had this patient who came from Australia. I know his name. I won't take his, I would call him MM because his name is M and M. He came into my room and he was very happy to do the procedure already. And I said, okay, fine, let's do this hairline. The marking is done. And the OT is already prepared. I said, everything is set. Team is waiting. I trim his hair. We do the hairline marking, take some pictures. He just comes at the door of the OT. He looks everything around, and the panic button hits. He walks up with the OT clothes outside my clinic, and he's home. He doesn't even return back. I was like, your money. I'm like, you keep the money, I'll come next time somewhere later. I said, that's perfect for me.
So that's called phobia for treatment. Yeah, I'm sure everybody's experienced this. I'm sure he must be having some needle phobia or the pain phobia, which, because of which he really returned back. Dr. Choksi, would you like to?
As far as patient management is concerned or the interaction is concerned, it's always very jovial and friendly atmosphere we have. And I remember a lot of incidences when we have been operating, and it's non-medical things which happen actually. So one of my client I was operating, and the phone was repeatedly ringing, though we normally ask them to keep it on a silent mode. And because my team was doing the implantations, I just went there, picked up the phone, and the person who was calling was named as Tension.
Sorry?
Tension. The name was Tension on the screen. So I said, is it your wife's number? He said, yes.
Yeah, that's...
My nani, after hearing this, that this patient ran away, she asked me, उसने 25,000 रुपए दिए सिर्फ बाल मुंडाने के लिए, because he had shaven his hair and gone home now. I said, हाँ 25,000 रुपए मैंने लिए सिर्फ बाल मुंडाने के लिए.
Yeah, Dr. Gitanjali?
This common thing I always get is any patient that walks into my clinic keeps on asking me, "Aapke baal sache hai?"
I was expecting that. She has lovely hair. You all can appreciate that. And I envy her for that. Dr. Viral, please.
Well, yeah, actually, similar incidents, what Avinash said. And the patient just disappeared. He was also for another procedure. And he paid the whole money. He disappeared. He never replied back to his calls. I emailed him. I said, come and take your money back at least. And he still didn't. And after some 2-3 years, he messaged back saying that, it's okay, doctor, I've changed my mind, but you can keep the money. I'm like, I wish all patients would do that.
I wish we all had this kind of clients. So you don't have to really put in all your efforts. And of course, all the backbashing which happens after the treatments. So let's begin. We all know what is androgenetic alopecia, alopecia areata, telogen, scarring, etc. Let's look at the trichology basket. What do we have? Is it like monotherapy, or we're looking at combination approach? So I'm sure most of you have been doing these procedures. Let's go one by one. We'll start with Gitanjali, since these are the medical options. Dr. Gitanjali, which is your favorite treatment? Is it like a solo hero, or you would like to combine treatments? And how would you select your patient for these kind of treatments?
So my go-to is, of course, the history and the diagnosis. I vouch by the trichoscope. I can't function without the trichoscopy. Once I've diagnosed, the medical management is always the main line of treatment. You explain the patient the causes, of course. My go-to, of course, favorite is the PRP. Exosomes are just coming into my clinic. I'm also doing a research on biclotomide and dutasteride. We're doing a trial in the clinic. Too early to comment on dutasteride, but that also is giving good results. Microneedling goes as part of my medical line of therapy as a home care unit post-minoxidil. So that's something that I've been doing. But yes, PRP is something that I have a lot of belief. I have a lot of publication of my name on PRP. So that's my main line of treatment.
Yeah, since you're on PRP, let's take the second question on that. PRP versus PRF, any experience?
I think I still go with PRP. We did a trial also on PRF. Firstly, the time is very short by the time you have to get the fibrin out. Secondly, the injections are very painful. And thirdly, a lot of research says that of course, the growth factors are much better in the fibrin clot, but those growth factors have no action when it comes onto the hair. PRF has a bigger role in an acne scar, but again, the pain and the time is very short. You have to get it very fast. So I still go by the native PRP.
Okay. take-home message is, of course, it's painful and the duration of action is short. You have to use the PRF within 5 to 7 minutes after you've extracted it, because there's no anticoagulant in that, though it has some advantages. Doctor, any of you would like to have your views on this?
So I just want to, first I would want to add something, and I'm sure Vinay and Avina should agree with me. So typically, a lot of my patients have also come and asked me, but you do hair transplant, will you actually treat my hair fall? I said, I can't do transplants without actually looking at your medical management. So what did I do to improve that? I learned it from Dr. Gitanjali and likes of them. I actually read dermatology textbooks, because every patient who does surgery is going to ask you about how do I get silky hair, how do I get split ends, how am I going to condition my hair, which is the best shampoo, and if I have to treat his hair and transplant it, I need to maintain the other existing hair too. So medical management becomes a very, very important part of our practice. In fact, I start my patients telling them that, look, I can do the transplant and that's about it, but if you don't maintain it, there's no point. So I start with the maintenance and then I explain about the transplant. But yeah, going by this, PRP would still remain the keystone of the practice medically, but nothing to replace minoxidil and finasteride. If they would, we missed that, but if they would take oral finasteride.
We are coming.
Okay. Yeah. If we would take oral finasteride, I would be very happy about it. Minoxidil, now more and more shifting to oral minoxidil and topical finasteride. That is how the trend has become. And okay. So about all these treatments, I would only say right now I'm most excited about exosomes.
Exactly.
At present, and that's showing very good results.
Yeah, I'll be showing you some cases on that as well.
I think we always also have this growth factor concentrate injections, which are very popular. Of course, they also do not have any coagulant, so anticoagulants. And that's why I feel, again, the injection is much easier to put. It's much painless. And patients are very happy to take them. And of course, the duration can be pushed to almost 2 months. So you don't have to do it as PRP, where you probably have to call the patient every 21 days or 1 month. You can push it to 2 months. And maybe about 3 or 4 sessions in a year is kind of very good.
But you're talking about GFC or you're talking about
GFC,
growth factors?
Yes. No, growth factor injections. That is the concentrate available in different types of tubes which are available.
Not the GFC we prepare in.
No, not that one.
Because I think GFC is one of the most useless things that is come, because PRP is far superior. If you don't prepare it well, then you settle for GFC. But otherwise, I think GFC is useless. You just need to spin. It's nothing but PPP. It's actually indirectly PPP. It's very highly diluted growth factors which you're giving. If you take 8 ml of blood and you get 4 ml of serum, you can prepare it in lab. You don't need anything special for that. So that's a complete replacement. It's a very poor replacement to PRP, a well-prepared PRP.
Dr. Avinash?
That's a nice insight. I think I like that idea. That probably GFC, which is what I'm resorting to completely, instead of doing any PRPs, I'm probably going to think of both things together now, probably something more than that.
If you even speak to most of the companies and they say we have a patented molecule in it and plated factors, they don't even know what they are putting inside, okay?
Probably nothing.
Yeah, absolutely. They're just taking tubes, spinning it. Sorry to all the GFC users, but the reality is the reality. They're taking blood, whole blood, spinning it, putting an anticoagulant and getting you 4 ml of so-called lyse platelets with GFC, right?
Yes.
The concentration is never enough. If you have to you need 20, 30 ml of blood. And if you want good PRP, you will barely get 3 to 4 ml. If you get anything more than 10 ml, it's not going to be PPP. It's not PRP, it's PPP.
PPP, yes. More of plasma, which is mixed with the growth factors. Exactly. That's what they say.
Yeah, so the take-home message is the double spin method, the conventional method. You have to have some amount of blood, like at least 30 ml of blood, to get the right concentration of platelets to give you the desired results. GFC is more convenient for sure. And if you really want to increase the count of platelets, then you may have to use 2 tubes to get closer to the conventional PRP. Yeah, so let's move on. I think we had enough discussion of PRP versus PRF and different kits available for separating PRP. We all know about this medical line of treatment up to grade 4. in males and in females. Sinclair's classification is the most recent one, where we normally see clients coming at grade 3 when they notice that they are having thinning or they have whitening of their hairlines. And that's where they seek medical attention. So, yeah, I think, Gitanjali, you've been doing a lot of microneedling with dutasteride. Can you brief us on that? How does it work? How effective? Are there any side effects? Any ideal candidates? How is it administered? Obviously, it's microneedling, so there are other technologies also for injection. Directly, injections are also available, but they're very painful. So we'll stick to microneedling.
So how does it work? I think we know DHT1 and DHT2 blocker. Is it effective? I think too early. This is, I think, the past 4 months a company's launched for whom I'm doing the trial. Comes in a lyophilized vial. I think 18,000 is what they charge company. That's for 5 ml. You use around 1 ml for a patient, 0.1 by 0.1. And ideal candidate for this patient, I'm doing it in grade 3 and 4. That's what the trial calls in. Again, it's administered in the form of meso, Napaj technique, point by point, 1 centimeter apart. How effective it is? None of them are effective if you've not diagnosed it rightly. You cannot do a dutasteride on a grade 4 without a DHT blocker. So I always tell this in all my forums. No GFC, no exosomes can create a hair on a barren land. You'll have to address the issue. No topicals can help you here. So if you've addressed the issue, only then. And just coming back briefly on the PRP, I think you really need to know what PRP are you getting in. You call it a liquid gold, but I've seen a lot of clinics, they do full-fledged PRP and the count output is only 2.5 lakhs, which is as equivalent as to not even a PPP, it's as equivalent to as a normal plasma count. What are you doing? What centrifuge machine? What temperature? How are you holding it? Are you touching it? What vials? Are you using ACD? Are you activating with calcium citrate? If you've only addressed all of this and you've actually got a quantifier and got a 12 lakh count with a viable platelet, with good platelet counts, only then you call it PRP. Otherwise, all of this are, they have some humbug going on and everybody's injecting and aestheticians are doing, beauty parlors are doing.
Yeah, recently we also had some papers which said, through PRP patients have contracted HIV. And this is because, left, right, center, salons, beauticians, everybody started doing these injections, unhygienic conditions, using, reusing syringes, offering at a very low price, and they stand a tough competition to all of us. But I'm sure people know where to go if they understand all dermatologists are trichologists, and not all trichologists are dermatologists, right? So the take-home message is that you have to keep talking about, even though you are qualified dermatologist, you still have to say, you have to mention in front of your name, you are a dermatologist, you are a trichologist. Isn't it? Do you all agree with me?
The last one, how is it administered? There's also a paper which says you can use microneedling, but the DHT is where the hair bulb is. So I'm really not sure if with the derma roller we're reaching that level. I would still go with the injections.
I've been using since 3.5, 4 years injectable dutasteride. It gives, I just like it. It gives fabulous results, but I only inject it because it has to go to a depth of 2.5 to 3.5 millimeters. So we normally give a block and we inject it because it's very painful. So you have to, and plus it's lipid based, the solution is very oily. So you dilute it 1:1 or maybe even 2:1, but always give it with the block, and if you want best results, inject it.
Anyone here?
So basically, again, to inject, I would always do as a periphery or a field block. So once you have enough block, I think you can go with injecting maybe about 250 injections and the patient still knows nothing. You ask him, I've done about 40, and he says, oh, I felt only 1 maybe. So that's the beauty, that you should do a lot of block and you should practice, I think that, and safety, of course, in your clinic with a lot of anesthesia, safety has to be well in advance. And then, of course, you can use local anesthesia to your advantage.
Dr. Vinay?
I just came across injectable dutasteride actually in the practice, though it has been there on the international forum as a discussion for enhancing the hair growth. And I personally do not have any experience of giving it, but I am definitely going to start.
So I will just share my experience here. So, all know the pioneer of trichology in India, my mentor, Dr. Rachita. I had attended some of her sessions and I started doing this procedure, microneedling with dutasteride. And it was an award-winning paper at Trichology 2023, June 2023 last year. So I'll just show you a video later how we did it, what we did. Do you want to see? Of course, everybody knows how to do microneedling. Now, the only thing was, I don't know how to play this, but anyway. So, obviously, you create channels, that's microneedling. And then, that time, there was no dutasteride available, right? It's recent, as Gitanjali said, she's just doing over the last 4 months, and it's very expensive. So, these dutasteride capsules are available. You take 4 of these. It's a strength of 0.5 milligram. Sorry, you could play the video? Achha. Can somebody play the video, please? So what you do is create channels with your microneedling device. Take 4 capsules of dutasteride. Comes with a strength of 0.5 milligram. So take 4 of them and aspirate with the help of a syringe and needle. And then infuse it after you've created the channels. And we've done a study on this, 30 cases. And this was presented last year at Trichology 2023. And I'm happy to report that, yeah, it was an award-winning paper. But yes, your questions that you have to deliver at a deeper level, you could increase the depth of microneedling. Okay? So we did it at a depth of 1.5 millimeters. And if, in some cases, if they could tolerate, we went up to 2 millimeters. Okay. Coming to thread embedding therapy, I'm sure most of you have heard of this. Any experience, Gitanjali? I will always start medical line of treatment with Gitanjali and then move forward.
So I have done very selected cases, though I teach a lot of threads on scalp, but I'm not a big fan of I think microneedling does a fantastic job of doing micro injury. You don't need to put threads. Of course, it acts like a foreign body and keeps acting. That's what the paper speaks about. But I think with microneedling every day, you can get the same result. Why unnecessarily add to the price? Pain is too much.
Yes, Dr. Viral, any experience?
Same, I mean, you have such good, better options available. So why would you look at threads? But arguably the one who's got the first publication is a very, very dear friend, and we keep fighting every time about threads versus non-threads. And she keeps, so it's from, the first publication of threads is from India. It's from New Delhi, by the way. So it's a very dear friend of mine. She's a dermatologist, yeah, Jyoti, Dr. Jyotirmay. Okay, and we keep fighting on this. And she says the only thing is, and which makes sense to me, the only point which makes sense, it's if a patient is coming once a year, he doesn't stay in the city or the country, and then you can look at that because threads is to be done once a year. So yes, okay, maybe you can look at that option, but if otherwise, we have so many better options available.
Very true. If patient cannot come, not staying here, staying abroad, what else can you offer to the patient then in such cases other than home care? So that's the only indication where I feel it is worth talking to the patient.
I think even crown is a good indication for doing threads because crown is a place where you really see very bleak results. Even if you've angled the hair in a particular way, with less number of grafts, you cannot achieve a fantastic results in the crown. So sometimes I think that could be also an additional thing that you add in the crown, maybe about 100 threads, 1 inch each. And that will also, like circumferentially, you can place it all around like that. I've seen only one case like this, seen, not done. So I've seen only one case, but of course I think that could be an option to select.
That's a lot, 100 threads.
Oh, a lot of doctors now place the 100 threads and then they inject the Regenera or the PRP through the threads. So that's what is the way you do it, once in 6 months.
So thank you for the inputs, points taken. Yeah, you can consider. One is only when patient cannot come to you for repeated visits. But yeah, somehow we have seen there were good results. We've used about 40 threads. The length was anywhere from 25 mm to 38 mm. I felt using a little longer thread was better because you need less number of threads. And I also used the screw threads over the mono threads because they probably release more growth factors as compared to the mono threads. So that's one of the reasons I used to use those, though are slightly more painful than the mono threads. And now you also have threads of 12 millimeters available if somebody wants to try that. Dr. Vinay, any experience?
It's something new for me, and there are certain treatments which come in the market, and we get very excited about doing that, but I never got excited about using threads for the scalp, because there has to be need for doing certain things for hairs. If you are not achieving the growth that you are looking for, then there are need for a lot of things which can come in the market. But most of the things, people are just experimenting. I went to an international conference and they are putting follicles into the wound to just see how they can help the wound heal. So it's just sometimes a paper presentation, or maybe just to stand out as a different person amongst the scientific community. People are doing things. This is what I
Not
feel.
many studies. It's just popular over the last 2 years. There were some references which I took, and I then did the study on this as well.
Using follicles in vitiligo also is known. So for vitiligo to get the, so that's why they say the regenerative medicine is into the action right now.
Right. So coming to the hero, exosomes are the new hero today. So let's listen from, again, starting with exosome. Any experience, Gitanjali?
I think he's the right guy to.
Yeah. Next, I was coming to Viral because, I know he's done a lot of work.
Yeah, no, I got exposed to it around 3 years back, and I started using it 3 years back. It wasn't available here. I was outsourced. I was getting it from Korea. Of course, very skeptical. Started using it, found results. Used it in 4 of my patients who were stabilized with medical management and PRP for a number of years, 5 years plus. They improved further, to my surprise. And that led I started researching more into it. Of course, we don't know whether animal-based are better, plant-based are better. Let me tell you, there are arguments in favor and against everything, okay? People talk about transmission of diseases or putting in some kind of RNA and DNA, but they are, again, just proteins. They are not microRNAs. You're not actually sequencing the entire DNA or the microRNA. They are parts of the messenger RNA. So it would not matter. And why would you not use the animal source or autologous source? Now, of course, which exosomes, Wharton's jelly, mesenchymal cells, stem cells, placenta derived, would probably be the youngest stem cells. So if you get exosomes which are cultured from them, you probably would have the most purest, okay, arguably, there is pro and against for each. But arguably, you would get the purest kind of exosomes as compared to what you would do from bone marrow or from fat cells or from any other source, whether it is bovine or plant. Arguably, plant is safer. Again, some people claim that because you don't have the animal transmitted diseases when you use the plant-based ones. And again, they say that it is only the microRNA, you're using only the proteins, so it doesn't matter what the source is, right? Whether you should inject or not inject, the only country which allows injection is Korea and UK. Everywhere in the world, it is off-label to inject, and you have to use with microneedling. You're not allowed to inject. Now, my experience is mainly for hair, I'm talking, not for face. I think that Dr. Gitanjali would be. But yes, I use a lot of exosomes. I have shifted 30% to 35% of my PRP patients to exosomes now. And the results are very good. One thing you can see that the results come faster. They are very, very instantaneous. You don't have to wait for too much time. Maybe in a couple of weeks, you see results. How long do they last? I'm still evaluating. At present, I think it's something like what PRP lasts, 3 to 4 months, approximately in that range. But right now, mostly I'm using animal-derived, Wharton's jelly or placental-derived exosomes. That is what we are using. The count and the purification is important, how they are stored. So counts have to be, if you're using in hair, have to be 10 billion and plus. If you're talking about the vesicles, if you're not talking about the vesicles, then you're talking about a count of, if you're talking about the cells, then 3 billion also is good enough. Of course, there are different, I've seen exosomes which are 48 billion also. Vesicles, again I'm talking about vesicles. So this is where we are with exosomes. I've heard a lot of people talk about it. I've attended a lot of conferences regarding this. It's still little blurred where PRP was 20 years back. Nobody knows exactly how often or whatever to use it. But as of today, I'm using it like a PRP, maybe once in 3 weeks or once a month, and then continuing it thrice a year as a maintenance.
You initially, how many sessions you do, Dr. Viral? 4. And then you do every 3 months. And which is your favorite?
I'm using a lot of them, so
Yeah,
most of them are
that's why
Korean. Actually, all of them are Korean practically.
No, like you said, the adipose derived or the umbilical
I
cord.
said Wharton's jelly. Now I'm trying to.
Wharton's jelly.
Yeah.
So there are some umbilical cord derived as well.
Umbilical cord, Wharton's jelly, I mean,
It's
they're
the same.
similar. Like I
Okay.
said, they're the youngest stem cells. So arguably they produce the best exosomes. Now you have your self exosomes, right? Which is what your Regeneron is claiming. You actually get there. You have from T Labs another kit which you derive from fat. It's called Exomine. It's not launched in India yet. But fortunately, I've used around 5 patients. So when I was talking about these, and I happened to speak to one plastic surgeon who's using them for last 4-5 years, Dr. Tung Teriyaki. I don't know if you've heard of him. He's very famous. He's from UK, and he's one of the pioneers of exosomes. So he's saying you should not use your own exosomes for yourself, because if you have hair loss problems, then it's not going to solve your problem. Okay, it actually got me thinking, is he right or wrong? Is he right or wrong? I think he's wrong, but we need to, it's a thought stimulating, it stimulates your thoughts, you know.
Particularly your grey matter.
Yeah, but if you use your own, it's like PRP. At least you're definitely sure of no allergic reactions and no disease transmission.
PRP is autologous, right? So obviously we would have the same analogy if you're using something else. Yeah, but exosomes obviously are not derived from you. Exosomes are coming from umbilical cord from where we do. I mean, it's a pooled sample, right? And of course the processing and whatever they are doing to remove all the immunogenicity. But is it an FDA approved treatment? Are there any legal aspects to be considered during the procedure? Any of you, please?
It's not an FDA approved procedure. None of the bottles of exosome ever say that it can be injected. None of the growth factors also never say that it can be injected. None of these polypeptides, the QR, most of them, they do not mention that it can be injected, because honestly, I don't think we've ever got it to that level to find out what happens when it is injected. These are for topical usage, and all the studies and the data and the publications are for topical usage. Exosomes, again, as Sir said, it also depends on where it's derived. We have an aloe vera exosomes which is claiming to give good results. Then you have mesenchymal, you have the Wharton's jelly. Wharton's jelly, umbilical, placental are all the same. At the end of the day, it's the count that matters, the way you've stored it. Again, it's once in a month is what the company says. Korea is a big hub. Any conference that you go to Korea, the Korea Beauty now that happened, I think had some 38 stalls of only exosomes. For everything, bone exosomes, you have hair, you have skin, you have pigmentation exosomes, and now, of course, there will be like more and more and more research onto it. Honestly, how true it is going to be, we don't know, but of course, it's not at all FDA cleared. I don't think even in Korea there is any clearance from any side.
So time will tell eventually. Yeah. Yes,
Yeah,
doctor.
so only thing I think the tubes that we use for creating these GFCs or other things, the safety efficacy of the tubes, if they're using acrylic or using some kind of material, that if it's taken outside the body and centrifuged, they have safety certificates up to that. But some of the companies are claiming that they have certificates that it can be injected back also. So that the safety of any pyrogens or anything which is there, and there is nothing there that can cause any side effects to the patient if you're injecting it back. So there's class A, B, C kind of certifications these tubes have. So if the tubes are saying that they're safe to inject, of course FDA has no approval for sure. But if their safety is what we are looking at. Patients always ask this question, how safe is it? So it's not going to be like 10 years later, I'm going to have cancer of my head or some kind of a skin cancer. We are looking at something like a safety norms that can be really followed well. And if it's under that form, I think we should take it a chance to go ahead and do things.
Yeah, but for that matter, besides topical minoxidil and oral finasteride, nothing is FDA approved for hair at least. Nothing is. not PRP, not GFC, nothing, not PRF, not injectable dutasteride, not mesotherapy, nothing is. So how much important is FDA approval finally?
Have you ever noticed any kind of complication with PRP?
Maybe nodule, persistent pain for a little longer. One patient had abnormal swelling. Maybe that could be some kind of a reaction to the serum or something. But nothing major. I mean, everything which settled down quite fast.
Yeah,
Dr.
similarly,
Vinay?
I was with one of the, yes.
Some of the surgeons who just start doing PRP, I think they misfire the injections and send them into the blood vessels. And I have seen some clients in, say, 3 to 4 hours or maybe in 12 hours time they have fever with chills, almost like a serum reaction that you have, and this fever is very high grade. Apart from that, pain can be a thing. These are a few things we've seen.
Yes, doctor.
Similarly, what Dr. Viral said, I think hematoma is what I have seen with one of the person who was injected, and the patient was referred to me later to take the surgical management. So I had to open up and remove the clot. Otherwise, I think there is nothing major. Of course, some kind of soreness, which one of my patients actually never came back for a next section, and a German patient, and I was like, okay, fine. I think Indians are tolerant enough. People internationally are not tolerant enough. So I think I still take that. Okay, fine. Indians can bear the pain. Yeah.
Yeah, Dr. Gitanjali.
Very commonly what a patient does is he's already applying minoxidil and he comes in between to do a lunchtime procedure and he's not cleansed his scalp well. So you'll have to tell the patient come with washed hair. You always apply a small layer of betadine whichever area you're injecting. Keep multiple insulin syringes. So after around 8 or 10 pricks, I think you need to change. We give a small ring block when we start injecting, so pain is better. But there could be a chance of lymphadenitis at times if the patient already has folliculitis. I think such patients should just not be taken because you're injecting sometimes into a bacterial pustule. Most of the doctors forget to tell that don't go home and apply minoxidil, and we've seen a bad reaction happening from some other clinic coming to us, open channels, and then minoxidil. Hair dye would sensitize the scalp, and a lot of clinics do microneedling before they inject PRP. So no hair dyes at least 3 days before the session and at least 3 days after the session. A lot of head and shoulder shampoos have menthol in them. A lot of patients would use it next day morning and say my scalp started burning, or they'll go back and use a salicylic based ketoconazole based shampoo. So these are small tiny bits that you'll have to put on the paper and do it. So diabetic patients, cover of antibiotic, topical antibiotic shampoo post. So small things helps to avoid complications.
Betadine scrub works well before and after the procedure. Immediately before they come, we tell them to use a betadine scrub and come, and then post care is again the next wash after 24 hours again with a betadine shampoo. So that reduces the risk of bacterial or any other kind of infections. I have seen a lot, in 2 cases I've seen lymphadenitis. Now what was the reason? Don't know. After taking all the precautions, post care, whatever we had to do, we had done. Ultimately patient was scared and we had to stop the procedure. I mean, give him other options of treatment, non-injectable options of treatments. I'm sure all of you must be doing some mesotherapy, low-level laser therapy, etc. in combination with other procedures. So then we don't have much to offer to the patient other than medical line of home care treatments and all that. Any experience with bicalutamide? Again, this is a recent thing. I mean, Gitanjali, you must be knowing about this. It's available now.
So again with dutasteride I'm doing it. I've also started giving oral bicalutamide to some people who were not doing well with aldactone or with the finasteride 5 mg. But again, too early to speak on bicalutamide. Again, a painful injection. So.
Yeah, again, same, the problem with dutasteride and bicalutamide, very painful injections and expensive, of course. Oral, we know flutamide gives fatal hepatic necrosis, and the risk of that is much lower with bicalutamide. So you may consider, of course, as she mentioned, that if there's a failure to finasteride or aldactone, it can be considered as an oral treatment. Any other panelist having experience with bicalutamide? Okay, we'll take it further. Let's come to your favorite. So far going good, and all the surgeons, hair transplant surgeons agree that a medical line of treatment is important before and after you do a hair transplant procedure. So point well taken. We'll start again with Dr. Viral. Questions from the audience?
Yeah.
Yes, please.
Something that Dr. Sonia presented was a lot of clinics break open the dutasteride capsule, which is actually an oil formulation. So I really don't know what is the specific gravity of the capsule that you're using.
I'll come to that a little later.
Yeah, so then people break that capsule and then do microneedling, one, followed by PRP2. And a lot of people also do low light laser therapy in the same session. So it's a 3-session. So a lot of people also combine Kerawave hydrofacial for the scalp and then do PRP. So maybe additive, but you can always avoid. As you rightly said, you're anyways triggering by the prick.
I think her question is whether you combine PRP injections with microneedling. That's her question. What is your opinion on that?
Yeah, I think she's completely right because you're irritating the scalp more. Yeah.
And ma'am, what about minoxidil? Because I tell my patients to apply minoxidil the next day and they've had no problems with PRP.
Yeah, it's absolutely okay with the new cetisomal and trisomal variant that we have. Alcohol is what irritates, it's not the minoxidil.
Yeah.
So
Because
the new
anyway,
variant, I don't think there's a problem. But the initial, the alcohol one natively, it caused a lot of irritation and burning.
because earlier people used to do minoxidil and derma roller in the same session, like
Yeah.
when I was with my MD. So I don't know.
Again, for penetration, no?
Correct.
For better penetration.
Thank you.
Yeah. We are on hair transplants right now. Dr. Viral, all of you can interact, please, all three of you. So we've crossed the borders of grade 4 and grade 3 in case of women, Sinclair's classification.
I think all these questions are, of course, quite, I mean, everybody in the audience would know FUE, FUT. Just one thing I would say, FUT is never dead, okay? There are certain indications for FUT which are grade 6, grade 7, which are very, very tiny donor area. And when you're going to remove it right from the center, from the meat area, your number of grafts you get is going to be of far better quality and numbers as compared to FUE. Though, I mean, in 2006 when I was doing FUE, I think it was mainly FUT. I would proudly say that we started as a revolution and everybody started shifting to FUE. But there are certain candidates who are still candidates for FUT. But more important, I think, I would like to stress on the point, and all of us would have seen this, that patients have done so many medical managements, so many medical therapies in a grade 5, grade 6 and grade 7. And then after 3 years, they come to us for a transplant. So just one word of caution, if the patient has absolutely no hair roots, no follicles, please send him for transplant if you don't do it, because it's not going to make sense to give him all this medical therapy. It's really not, you're just going to try maybe in your enthusiasm to give him some kind of results, but it overall spoils the name. Also, by doing a lot of invasive procedures like threads and all, we've seen a lot of fibrosis happening when you're doing a transplant, and it actually makes the job a little more difficult. So yes, too much of intervention may not be the best idea. Beyond one point, if it's not working, if you feel, just send it to somebody who does a transplant. So that is just something I would like to add.
Yeah, absolutely. I think grade 3 and grade 4, or patients who are desiring a hairline, I think that's, you should not really push them that their hairline will come back with medical management. You should tell them, okay, fine, the temples, the temple peaks, your lateral hubs can be easily filled with transplant. And of course, you know, the hairline designing is the most crucial part which will really make and break their hairline. And of course, the framework of their face. So I think you should just get them a good framework. And yes, for the top and for the other area of your scalp, the vertex, you can continue the medical management, but you should make it a point that you refer them to a surgeon who can give them a hairline. Or even if somebody who has a lot of area to cover where the follicle is completely devoid, or you see very lanugo follicles which are so micronized that you can see probably with a trichoscope, but they are not going to respond to medical management, you must send them for transplant, because that is the way to go with anyways, which is grade 4 and above.
So trichoscope, everybody should have a trichoscope in your practice. This is one of the take-home messages. It's a great tool to help you diagnose. It helps you also assess, how your treatment modalities are working for them. So yes, you must learn a little bit of trichoscopy and also learn how to evaluate the results. And it's it's also very objectively satisfying to the client when you do it and show them the results. So yes, definitely it has been a very useful tool for all of us. I'm sure all of us agree to that. Hair transplant then and thereafter, your question, Dr. Avinash.
Yeah, so I think long back people knew that transplant was done by probably plastic surgeons alone, and there was also called as a scalp reduction surgeries to start off with, maybe 35, 45 years back, and slowly it went down to something like strip transfer. They would take a strip and transfer the strip right in the front, and the hair would grow long, and you can actually have a ponytail at the back. And of course, as a plastic surgeon, sir would know better. He would talk more about how things have evolved. And I started off my journey in 2009 with punches, which was 1.2 mm. And that's where we started doing grafts, which was kind of little bigger and thicker, maybe about 3 hair, 4 hair, sometimes 5 hair also, because the punch size was very big. And of course, in 2014, 13, we started moving on to 0.9, 0.8. And the punches size now is almost 0.8 and 0.9, which is like a standard for most of the grafts that we take out. So this has been the journey throughout the time. And of course, with the instrumentation, the fineness of the tip of the forceps, or being implanters for that matter, a lot of these implanters have improvised with time. And people have started using the direct hair implanting method, which is with the implanters, or people are doing the forceps implantation also with a very caution method where they do not touch the follicle or the root. So everything has gone throughout such a beautiful phase that, and of course in the last 4-5 years, there's been a large advancement with people are doing up to 11,000, 15,000 grafts. I don't know where do they bring that grafts from. But of course, in my practice, I have reached up to 7,500 grafts with, of course, doing beard hair, chest hair, underarm hair. Probably these are the hair we also take and fix into the patients with grade 6 and 7. So of course, the journey has been through like this, and I think most of the doctors, surgeons here would agree that we have also evolved with time.
Dr. Vinay? Dr. Vinay, please.
Okay. So basically, experience from FUT to FUE has been very revolutionary, and when I learned from AHR Dublin the whole FUE procedure, I was experienced in FUT, and we had this healthy discussion, and they said ki up to 15,000 hairs you can reach with the FUE, and it was very new for us. So FUT, I had seen the number of grafts you can get, so I never believed that. But maybe in 4 to 5 years of our practice and repeated surgeries, we reached there. And as Dr. Avinash rightly said, now even doing 7,500 to 8,000 grafts, and I see international surgeons sometimes doing 14,000 grafts or even 35,000 grafts over a period of time, like Dr. Umar and other people, it's possible. And they even take hairs from area like the whole body they are using, including leg and your arms also they are being used. So it's a very revolutionary technique, and I don't see a limitation to the technique as of now. So any client coming in grade 6, grade 7, it's always possible as long as they have hairs, whether it's on the body or on the scalp. We are more than willing to.
Any experience with female pattern hair loss? Hair transplant?
Female pattern, we have been doing maybe 5% of the practice. The only thing, take-home message, which I feel, because we are doing between hairs, and the sterility and the cleanliness of the scalp is very important after the transplant, because there are high chances that these females would develop a lot of seborrheic issues, and infection is also possible.
Have you seen a lot of telogen after,
Shock loss is something that we always tell the female clients.
Females?
Yes. So 2 months, we tell them 2 months you should be ready. Either you put the hairs on this particular part or use hair fibers after maybe 15 to 20 days. And that is how you have to circumvent this problem, because for females going back to their work, it's very difficult with the shock loss that they can have. So ideally, you should not do too many grafts in women. You should always span it over like 2 to 3 sessions over a big period of time. So the shock loss is not very evident.
Excellent. Dr. Viral, any inputs?
Start pre-treatment 3 to 6 months before, shock loss will be unheard of. So that's one thing, especially in females, if you're worried about shock loss, just start them on treatment beforehand, medical line of therapy, and then shock loss is taken care of. In very, very rare to find it there.
Actually, the decision to do a hair transplant in a female would normally happen when they've been through everything. So even if we have been, though he is correct that definitely medical line should be the first, and they don't have a patience sometimes. And they are like too much psychologically disturbed, and then we have to put our hands, like do the transplant for them. So there I think we have to give them that information of shock loss. Otherwise he's correct that medical line we should do as long as possible.
Great. So we have, yeah, medical line, again stressing on the importance of medical line of treatment.
So I think it's right
as
actually that you
important as doing
tell
a
them that
surgery.
you earn your transplant. So to earn your transplant, you have to work towards getting the medical management first, maybe for 3-4 months, and then you take a date for surgery. You don't book in the day they come in. So I would always tell them you earn your transplant. And how you earn is by showing trust in the medical management. And then of course with that, we would hardly see any telogen effluvium or a shock loss which is coming in.
Also, most of them come to you not with the mindset of surgery. So you can also buy time, show that how the hair is improved with the medical line of management, and then how it can be improved further with the surgery. So that's how we generally take them through, especially if they have phobia for any kind of surgery. Can we move on? This is Dr. Avinash, your case. You'd like to talk something about?
So I try to practice when patient with grade 6 and 7, something which is like a combination method. We take a strip from the center where the stitch has been done. You can see the central stitches which has been done after trichophytic closure, and where we easily draw about 4,000, 4,500 grafts, which is from both the ear to ear. So you basically draw a line from above the tragus, a perpendicular line, and from that line that is about 2 to 3 centimeters above your ear, you draw a line which is like a smiley line. So that is the whole zone, with center would be about 1.5 to 2 centimeters. And of course, as you keep going at the edge, maybe you can have the edge reduced to about less than a centimeter. And of course, you can do a combination where FUE is taken from above and below that. That allows the stitch also becomes more relaxed. So the approximation is much better. So you can do easily up to 7,500 to 8,000 grafts in such patients, where you take maybe 4,500 from the strip and about 3,000 plus 4,000 grafts from above and below the areas which is available. Only thing is, yes, sometimes if you tend to go in the non-safe zone, which is, it is different for every different patient. So you have to evaluate that right. So you can probably see that results over 10 years duration, 15 years duration, they come back saying that they have lost the planted hair, which is also evident. But of course, when they're doing such large sessions and large numbers, you have to tell them that this is a high possibility, that we may sometimes approach a little thicker zone where there is good number of grafts, but the graft may not have a higher survivability for years together. Because of course, in the past, maybe 20 years back, 15 years back, there was stamp paper guarantee that this lasts will for 25, 30 years. Which is of course nobody does in today's time, but we know that the graft will survive for 10 to 15 years. But after every 15 years, you will see at least every 5 years about 10 to 15% reduction in the hair, transplanted hair also. If anybody differs to say about that, please.
100%. People lose their transplanted hair if they don't take care. And that's a well-known thing. There are a lot of publications on this. So people guaranteeing 25 years and guaranteed and all, it's silly, because people lose transplanted hair. We've seen it over time. The only thing that can prevent and reduce it is medical management, which continues lifelong. So please keep that in mind.
The discussion is going really great. The results are excellent, Dr. Avinash. And I'll skip a few oral minoxidil finasteride for now. I will take some cases because we need to also wind up the session. Dr. Viral has a flight to take in the evening. We'll talk about this a little bit. This case had an allergy to topical minoxidil. That's where you consider oral minoxidil. Now also we have sublingual minoxidil. This is the allergic reaction to topical minoxidil. We also tried the aqueous formulation. Finasteride and dutasteride, we'll take it a little later. So great hair doesn't happen by chance, it happens only by appointment. This is the first case, 40-year-old male. Dr. Viral, would you like to contribute to start with?
Of course, trichoscopy, medical history, everything is very, very important. I'm skipping all those parts which are very, very obvious. But yes, start him on medical line of therapy. Definitely, and tell him that he will need his hairline to be filled for sure. 3 to 4 months of medical line of therapy. In a lot of cases, the center and the vertex would improve in this case. It may or may not. Of course, you can't predict, but he definitely will not get the hairline that Avinash was mentioning. Whatever you do, he'll not get his hairline back. So he'll have to consider transplant if he wants that. Or if he's happy with just increased density of the existing areas, then that's it. You can postpone the transplant to a later date, as depending upon what he wants.
Yes, so important
Because,
point
because
to
he's
note.
40. Of course, if he was 25, I'm sure he would want his hairline back for sure. Maybe 40, he still may be okay with just increased density of the existing hair.
So point to note that he will still need a hairline transplant in addition to medical line of management. Let's see the results. This is the medical line of management. This was done for 6 months. This was microneedling with dutasteride. This is the same thing which I was talking about. So this is the solution which we take in a syringe, and the molecular weight of this is less than 500 Daltons, and that's how it can penetrate the scalp along with microneedling. If you just apply on the scalp, it would not, but along with microneedling, yes, it does. And this was the trichoscopic evidence. We generally take from the temporoparietal, right, left, and the vertex area. You can appreciate the new hair growth. You can see the conversion of terminal vellus hair to terminal hair. You can document the new hair growth as well in all the pictures over here. So good treatment to consider, especially who patients who are not willing for PRP. You know, PRP means they are scared of taking blood and then injecting it back into the scalp. So that's where we considered doing this treatment. Yeah. Case number 2, who would like to take? Dr. Avinash, would you like to take this?
So
Dr.
I would,
Gitanjali?
yeah, I think my go-to would be, of course, topical minoxidil, oral DHT blockers. Dutasteride is my choice, and oral minoxidil to here because I see shorter anagen phase. Good treatment for the first 3 to 4 months, and again for the hairline, I don't waste time after the complete hair filling has happened. I immediately refer them to a hair transplant surgeon. I think a lot of dermats keep hoping that the frontal would respond. It never responds, and then what happens is basically you're wasting time. So the moment you think the quality is good and the donor area is now very receptive, I think you should just transfer your patient to the surgeons who could take care of them.
Yeah, it's only when you're not willing to go for a surgical transplant or
then
something.
I think you retain the patient. So true. The patient needs to be willing, but I think right education, because I think as dermatologists, these are the patients who first come to you. And I see a lot of dermats wasting their time actually. They need a transplant at the right time. So the moment you have a good vertex and biparietal fullness, you don't wait still for the frontal after 8 to 9 months. So you just transfer the patient.
Excellent.
I like
Yeah.
to add even PRP to the spectrum of treatment for this particular client. That will also help him.
Yes. I think I'd keep one case for each now. Huh?
Yeah.
So adding to it, actually.
I think here this
Yeah.
patient needs to be built in his confidence by doing medical management first. Once the hair starts to grow and he sees some kind of vertex filling, then only the hairline can be done. But most of these kind of patients, they want everything to be filled. They say, doctor, do me 5,000, 8,000, 10, whatever you can just fill, keep filling. But the importance is what you have is gold, is diamond. You got to save them first. So every diamond you keep very closely in your locker and you will take care of that first. You don't buy diamonds all the time and keep putting inside and don't care about what you have. So what you have is first restore them, and of course you can add between them as a hairline or whatever.
Yeah, so conversion of vellus to terminal, very essential before you proceed for any surgical procedure. This was again a trichoscopic image. Generally we have the scale to measure 1 centimeter from the temporoparietal or the hairline on both the sides and from the center as well. So we know we are taking at the exact place when you're doing a trichoscopy. So when you're documenting results, this is very important that you take from the same place, the pictures. This is a 35-year-old male. We'll move to Dr. Vinay.
This client, if he has never taken any medical line of treatment, we should start that. But definitely his crown requires a transplant to be done. It can be scheduled maybe in 3 to 4 months time after the medical line of treatment. Or if the client is willing, we can straight away go for a transplant also. The frontal hairline plus the crown we should do, and medical line of management to make the hairs which are still there better.
So this is done with PRP, 6 sessions of PRP, and now we are maintaining him because he doesn't want to undergo a surgical hair transplant. Again, the trichoscopic evidence. This is a 32-year-old male patient.
I think this patient should go for medical management alone. I think he's not a candidate for a transplant at all. You should not plant
so
on him.
important to differentiate whether you need to refer to a surgeon or you can manage it on your own. So this is medical line of management where we had this outstation patient. We did scalp threads and home care with minoxidil and finasteride. For dutasteride is still not FDA approved, but yes, we have been using in our practice as of now. You know the difference, a 0.1 of dutasteride is equal to 1 milligram of finasteride. So even if if you're giving bi-weekly, it really makes a difference. Sexual side effects, other side effects are pretty much similar, so nothing to worry about that. So this is how we document results. This is a 56-year, obviously it's a case for Dr. Viral can take this.
Yeah, first the orientation looks, but I'm presuming that's the bald area. The vertex down there and somewhere down is the donor area.
Yes,
we need to see the donor area.
Yes, yes.
We definitely need to see the donor area. I don't know what he's got on the side, some big earphones or something. But yeah, only if the donor area is good, hair transplant. He's a candidate for transplant.
Yeah,
but
donor
evaluate
area
the donor
is good. Donor area is good.
So evaluate the donor area and maybe combine it with body hair, and he's a candidate for hair transplant.
So this was medical line of treatment at the end of 5 months. So still not ready for a hair transplant.
So one question from the scalp, how many grafts you would want to take at one given point of time?
Typically we don't cross 3,000 grafts approximately. It's not standard for everybody, plus or minus 15-20%. But we generally stick to around 3,000 because we want to shorten the surgical time.
Okay.
You rather do it over 2 days and
2 days.
yeah. So I think it's there was a lot of heroism in hair transplant surgeons globally in between, which has already come down, you know. So people are again sticking to this 2,500 to 3,000 range.
And also the punch size, probably what was 0.7, 0.8 is coming back to 0.9, where people saying that the scalp, the hair is very skeletonized. You need to have with a lot of tissue.
Indian hair, when they say that they're using 0.65 and 0.75, it's a joke. I know that they're just marketing. The person running is an MBA. He's definitely not a doctor, or he's been trained to say that. It's rubbish, whoever says that they get good grafts with anything less than 0.8 for Indian hair. Okay, where Caucasian hair are thinner, you may still get away. With Indian hair, whoever says this, please do not send them any of your hair transplant patients or refer to them or get any hair transplant done with them, because you definitely need punches larger than 0.8, which is a bare minimum. I'm saying bare minimum. It has to be maybe 0.9, and if you're using manual 1, because manual 1 mm punch is going to create a hole which is equivalent to 0.85 or 0.9. Okay, so standard is 0.9, 0.95 in most of the cases. Sometimes 0.85, but definitely don't cross 1 and don't go less than 0.8.
So in this case, how many grafts you would suggest this patient?
2 day, for us this would be a 2-day session,
2 days.
using mainly scalp, maybe adding beard hair, 6 to 6,500 grafts in 2 days.
Yes.
Do the frontal and the center. I would not touch his vertex in the first sitting.
Right.
Call him back, see his donor area. If I'm able to harvest more, or then look at beard and other parts of the body and then harvest grafts. We've done around 12 cases of pubic hair also. Okay, some patients have, I mean, yes, it's painful, but if somebody who's really desperate for his hair, you can look at that option too.
Around how many grafts? 400?
Yeah, no, average, average would be around 150, 180 grafts. Okay. But in one patient, we manage around even 300 plus grafts. So it depends, you know, I mean, so yes, you can look at different options.
So 2-stage surgery for this case. These are the results after medical line. We'll skip few cases because we've discussed again. We'll do the exosomes, ongoing treatment. This is single session of exosomes. You can see the, you know, only when he walked into the clinic, I could see a great change. I have used the umbilical cord exosome. This was on this patient we did 3 sessions. 1 month apart. This was a female, just single session. We all finished. This is again ongoing treatment, so I haven't documented everything. Yeah, done. So my mood depends on how good my hair looks. I hope you all agree with me.
Because 90% of your selfies is your hair, right?
Yeah. So I'm always worried about what the other person thinks about me, isn't it? So obviously my mood depends on how good my hair. I'm not born with great hair. I have very thin hair, so yes, I sometimes feel low when my hair doesn't look good. Thank you so much for sharing all your experiences.
Thank you.
And we had a wonderful discussion. I hope you all have benefited from this session. And if we would have time, we would have discussed more about oral minoxidil and oral finasteride, dutasteride as well. But yes, we can keep something for the next time. Have a great day, and hope you all my panelists really rocked the session with their answers. And I hope this was the best session of the day. Thank you so much.
Thank you, thank you. I would like to thank our entire panel for this session. Thank you for all your time. I think Dr. Sonia had more slides. I would also not be able to take questions now, but definitely once they're off stage, we could, take some questions. I would now like to thank them with a token of gratitude, and then we will have a group picture. And we can keep the applause going, please. Thank you so much.
It's a non-ending talk on hair. The more you can talk as much as you want. And we all are pawns, and we had to become the queens of clinical practice. So learn from the experience of others and start. Thank you, Shriyal, for this opportunity.
So while we have our panel stepping forward for a group picture, for all our attendees, we would now break for lunch. So we would come back at 2:40. Please be in time so that we can continue with our sessions. We have some interesting discussions lined up post 2:30. We have a session on psychodermatology, followed by body shaping, body contouring, and then we discuss fillers when we talk about facial augmentation mastery. So I would look forward to seeing all of you back with me at 2:40 p.m. Enjoy your lunch.